Hello, and thank you for joining us. My name is Courtney Ketterling, and I work for Syneron Medical. Today we will hear a presentation on the new product, MatrixRF, for fractional skin resurfacing. We're very fortunate today to have Dr. Amy Taub with us giving this presentation. After the presentation, we will have a short question and answer session. You can submit questions by text in the webinar screen. We will be limited in time, so we will try to answer as many questions as possible. Dr. Taub is the founder and medical director of Advanced Dermatology in Lincolnshire, Illinois. She is also an assistant clinical professor at Northwestern University Medical Center, the Department of Dermatology. In addition, Dr. Taub has been heading up the study site for MatrixRF. And with this, Dr. Taub, I thank you for your time today, and I turn the floor over to you.
Great, thank you. Thanks, everybody, for coming. So tonight we're going to be talking about the MatrixRF, which is a new way of resurfacing. Okay, I am having, there. Okay, so what's our agenda is we want to talk about the fractional ablative skin resurfacing market, a product description, how it works, and our clinical results. The laser skin resurfacing market is believed to be growing. It is growing, but it's also believed to be growing exponentially. The fractional photothermolysis technologies and Reliant kind of breathed new life into skin resurfacing, where we followed a curve where we were at large amount of downtime, and then everybody tried to minimize the downtime and get non-ablative lasers, and I think that we realized we could come about as far as we could with non-ablative lasers, and now we've got a new thirst for getting the kind of results that we were getting with skin resurfacing. And fractional photothermolysis kind of gave us a way to come back into the arena that was a little bit less downtime and also safer. So I think that that's kind of really taken off in the marketplace. And here is a graph that shows the installed base in 2007 was about 4,700 machines at about 150 treatments per year. So the total volume is about 706,500, and that's obviously increased significantly in 2008. Procedures are up about 40%, and the growth in terms of the number of procedures up 200%, and they're looking at 2009 and 2010 to being growth numbers like that, and we probably don't have anything that's as new as this, so the growth may not be there in the other areas. The sales of light-based skin rejuvenation devices are still projected to grow by 10% per year, from $315 million in 2005 to $501 million in 2010 as physicians add new fractional and other skin tightening technologies to their practice. And these unit sales are expected to grow by about 14% per year to 9,420 units. What are the advantages of fractional resurfacing? Why are we going back to resurfacing now? Well, fractional treatments reduce potential long-term scarring, hypopigmentation, and other severe types of side effects from traditional resurfacing. Everybody talks constantly about CO2 resurfacing as the gold standard, and you see a before and after picture that's like really wow. And we've never really been able to get back there with a one procedure or a short number of procedures. And the main reason is because of long downtime in our society. Very few people are willing to put up with pain and a long amount of downtime. But then the other thing is, on the other end, as physicians, we didn't really want to be offering anything that could potentially cause as much as 10 or 20% of long-term and late onset scarring and hypopigmentation. So many of us abandoned that as being too risky. But the nice thing about the fractional resurfacing is we're able again to go back and address a deeper treatment. We've never really been able to get down deep into the dermis. You can't, even with ablative CO2, you can only go so far, because if you remove the entire epidermis and the upper dermis, then you're going to really have a problem healing, because there's no place to heal from then except from follicles and other glands. Whereas when you have fractional resurfacing, you can heal from the columns that surround the areas that have been ablated or removed, and so it's a whole new way of healing. So you can directly address dermal issues, and dermal issues are significant when it comes to aging. Elastosis and wrinkles tend to be either absence of new collagen or absence of collagen, or a restructuring of the elastin so that it's not very effective. And this tends to be down into the dermis, as well as there's other issues like scars and pigment. And in the past, when we've done regular resurfacing, we've had to wound the epidermis and then basically the upper dermis and say that we're going to have a lot of remodeling in the dermis, but that was more secondary. We weren't actually wounding the dermis directly. Also, fractional resurfacing has less downtime, although it may have some downtime. Certainly has much less downtime than traditional resurfacing. So the whole idea of this is we swung the pendulum back the other way, and now we're kind of swinging it back towards the middle, saying, hey, how can we get these great results that we had, but also reduce our downtime and the risk to our patients? So let's just take a minute to try and understand what the difference between ablative and non-ablative is. I think most people have used the terms ablative, meaning basically burning the skin, and not only burning it, but having a plume of smoke go into the air, so you're really vaporizing the tissue. And hence, when you do erbium or when you do CO2, most of the time you need to have an evacuator with you. So vaporization and ablation are kind of synonymous, and this occurs at 100 degrees centigrade. I mean, the skin is so hot that it literally just the tissue flies into the air because the water has been heated out of it. And the wavelengths that usually are associated with this are 2940, which is erbium, and 2790, another form of erbium, and then the CO2 wavelength, 10,600 nanometers. And that's represented by these little white bars that don't have anything in it. There's also, though, another form of what we would call coagulation necrosis. So ablation really means vaporization. The tissue's gone immediately. But there's another thing called coagulation necrosis, or I would call it subsequent ablation. And that's where you're actually heating the tissue up to the point where it's no longer viable. But it's not so hot that it actually flies off of the skin. It's actually there, and then it's pushed out of the skin. And we see this with the fractional resurfacing. This is a kind of a new method of wounding. We get that at around 70 degrees centigrade, and the wavelengths of light that has been associated with that is 1410, 1440, and 1550, the traditional fractional resurfacing devices, where they basically create columns also of heating, but the tissue isn't evaporated right at that moment. It's actually expressed out of the skin over the next few days. Then there's subcoagulative heating, which occurs between 40 and 70 degrees centigrade, which is our more traditional non-ablative. There's no burning of the skin. It doesn't actually extrude out later or be vaporized immediately, but we're heating up the layers of the dermis so that we get some collagen conformational change, as well as some heating of fibroblasts to create new collagen over time. And then there's some that actually do a combination. And you could argue that many of these things, well, with erbium, it's almost pure ablation, and with CO2, usually there's a combination of both ablation and subcoagulative necrosis and subcoagulative heating. So most of these things are somewhat of a combination. If we look at the schematic, where you can look at these other laser-based fractional resurfacing technologies, if you look at the left of your screen, we've got neodymium YAG at 1440 nanometers. It goes relatively deeply into the dermis. And when we see the epidermal and upper dermis removal via superficial fractional tissue coagulation, the red stands for subcoagulative necrosis. The green is non-ablative kind of coagulation, not coagulation, but non-ablative heating. And then the erbium glass resurfacing, fractional resurfacing 1550 can go even deeper. Again, it's not vaporizing the tissue, but it's actually doing the subcoagulative necrosis, but it goes even deeper. And then we get YSGG, which is 2790. Now you get a very superficial form of ablation, and then the other kind of half of the epidermis gets some subcoagulative necrosis, and this is good for superficial tissue ablation, plus a little bit of dermal coagulation. So you kind of get rid of the epidermis and all the epidermal things like hyperpigmentation and very superficial wrinkles or textural type of issues. Erbium YAG is really more completely just ablative and vaporizing. It doesn't really do very much heating underneath. And then we've got carbon dioxide, which ablates a very small part of the surface, and then it leaves behind a fairly large zone of subcoagulative necrosis, and then there's another zone of some non-ablative heating. And the non-ablative heating is more correlated with tightening of the tissue. The MatrixRF is the first ablative RF device with clearance for skin resurfacing. So this is a really new technology. So everything we've talked about up until now has been laser, and laser is light. This, we are talking now about radio frequency, and we kind of associate radio frequency more with tissue tightening devices or non-ablative type of tightening devices. This is a whole new way of thinking about radio frequency. So for the current customers of Syneron, this is kind of a great low-cost entry to the fractional ablative market because you can upgrade your current platform with this new handpiece. And you can tune it. And we're going to talk about that later. There's 3 different types of software settings that can kind of mimic some of these other fractional devices that we have in the laser world. And the bipolar radio frequency is the newest technology for controlling fractional ablation and skin resurfacing. So it's 3 applications in one applicator. There's mild ablation and skin resurfacing, a shallow impact, which is similar to the primary clinical effect of erbium glass, or traditional fractional resurfacing. There's moderate ablation and skin resurfacing, or mid-level impact, which is similar to pure resurfacing with erbium YAG. And then there's an intense ablation and skin resurfacing with the deepest impact, which corresponds to the primary clinical effect of CO2 fractional. And then as we're going to show you some of the proven efficacy with the clinical trials and histologies. So there's 2 different methodologies. There's a deeper fractional impact with low coverage, about 15%, which means about 150 micron holes are made about 1 millimeter in depth, which is pretty deep. And that's good for wrinkles and laxity. And then there's also a more superficial fractional impact with high coverage, so about 40 to 60% with a 300 micron depth. And this is good for pigmented lesions and discoloration. This is a schematic to show you kind of the impacts of the MatrixRF versus the MatrixIR. The MatrixIR being a 910 diode plus bipolar radio frequency. Diode is actually one of the deepest, that particular wavelength is one of the deepest penetrating of all the wavelengths of light. And so you can see here that it's good as a non-ablative treatment for folds, but it is non-ablative, whereas the MatrixRF is going to be able to get pretty deep, down into mid-dermis for ablation. So how was it done? Well, this is kind of a very simplified schematic. You take bipolar radio frequency, chop it into sub-electrodes, and then you rearrange them. So there's some mixing and multiplication. You can kind of control the current by how you set these up and how you chop them and mix them. This is what the handpiece actually looks like, where you can see that the bipolar arrangement means that the RF current flows between the positive and negative electrodes. So it's flowing like this, and the control of this current allows varying degrees of tissue impact. So it's going to flow like this, and it's going to affect basically how we impact the tissue. And in the space of no current flow, there's varying amount of healing reservoirs that can be obtained. So in other words, in the areas where we're not getting anything, like in here, the tissue is impacted, and therefore it's basically like a fractional treatment. So this is called Select Pulse. It's the MatrixRF Clinical Advantage. There's 3 programs. We kind of already briefly reviewed them, but this gives you a little bit more of a visual. Program A being mild ablation and skin resurfacing with a shallow impact. And Program B being moderate ablation, so we're going to be ablating down into a larger part of the epidermis, and skin resurfacing or mid-level impact. Program C with intense ablation and skin resurfacing, and the deepest impact. Another schematic to kind of try to explain this, in program A, there's mainly heating and soft tissue coagulating, so we're talking about non-ablative and subsequent ablative, and then there's a little bit of ablation. And this represents, or is similar to, the current fractional erbium glass devices, which rely on mostly coagulative resurfacing. Then there's program B, where you have a fair amount of ablation, soft tissue coagulation, and heating, so kind of everything. And this more represents the ER-YAG ablative devices that are used for color correction and texture irregularities. And then we've got program C, which is much more heavily weighted toward ablation, some tissue coagulation, and a little bit of heating. And this resembles the impact of the fractional CO2 devices that produce high levels of ablation and partial resurfacing for treatment of rhytids. Here's some histological evidence of some of these impacts that we've made. If you look at this slide, you can see the ablation crater. And the crater is actually all the way here with the rim of coagulation below. So this is coagulated epidermis. It hasn't been vaporized, but it's coagulated. You can see it's pretty much dead. And then there's a thin rim of precoagulated tissue. And then over here we see the start of a scab formation. And this you see a scab that is shedding off, so it gives a kind of a bronzy appearance. And this is just to show that there's thickening of the epidermis, infiltration of leukocytes, so a little bit of inflammation, and then there's heating and shrinkage of this dermal collagen. The specifications are the applicator weight is only 0.6 pounds, including the cable. It's extremely light. This is one of the most ergonomic things I've ever picked up. It's very easy to hold and to manipulate. It's 170 centimeters, the umbilical length, and the applicator measures 15 by 16 centimeters. The treatment area is 12 by 12 millimeters, and there's 64 pins in each one of these tips. And the distance between the pins is 1.5 millimeter. And again, these are all things that could potentially be manipulated to produce different impacts at different times. So the program selection is A, B, or C. Total RF energy available is 2 to 20 joules. The coverage is 5 to 10%. And each tip is basically, it is a disposable. You only get 125 pulses per tip. And every 25 pulses, it makes you stop to kind of wipe it off with a little bit of alcohol, because you don't want, if you get too much char on it, it doesn't really char up, but sometimes you can get little bits of char, and it will actually it will short out the tip. This is what the tip boxes look like, and the applicator. There's a set of 10 treatment tips in each box. They cost $75 a piece. And there's also a set of 10 test tips. I'm not sure what they cost. You also get a user manual, the QRG, which is how to use it, and the software upgrade. This is what the tips look like. They come off. They just click in and out. They're very easy to use. Again, there's 64 dots here, and there's 1.5 millimeter in between each dot. The tip is controlled, by a tip ID, and it's inserted with the T facing upwards towards the applicator, and the mechanism recognizes the new tip, and it begins counting down the pulses, and every 25 pulses, the user will be instructed to clean the tip. After 125 pulses, the tip will stop functioning. I believe it's similar to Program A. There's a short treatment protocol with minimal downtime, and it can be easily managed with topical anesthetic, and there's single-use tips. So Program A, again, is going to resemble the skin improvements achieved with fractional ER glass. Program B, similar to just plain ER YAG. And Program C, similar to fractional CO2 devices. It has been cleared, and it's the only RF device for skin resurfacing on the market by the FDA for skin resurfacing and ablation of soft tissue. So let's look a little bit at some of the results. There were 4 beta sites, myself, Dr. Haruza, Dr. Sharon Laughlin, and Dr. Stephen Mulholland in Canada. And if we want to look at the demographics of the patients that we treated, they were kind of spread across the age range, with the majority in the 35 to 65-year-old range. Skin types, predominantly skin type 3 and 2. We did have some skin type 4. And the average age was 52. Only 3 subjects had had rejuvenation treatment in the past. So pain management is patient dependent. We worked pretty much with something that was similar to Program A, and we used an hour-long topical anesthetic that was kind of like a BLT. We had absolutely no pain issues whatsoever, and kind of came to the conclusion at the end when we rolled this out for our patient population, we probably reduced that to half an hour, but we have not used Program C, which is probably the most aggressive, so I can't really tell you what kind of anesthetic you would need for that. You cannot use the Synercool or cold compress pre-treatment or pre-pulse. And, of course, I'm going to show you a video in which you see me using the Synercool. So this was news to me, but it totally makes sense because we've been talking all along about bipolar radiofrequency and how cold is repelled. Cold areas are repelled by radiofrequency energy. So if we cool the skin too much, we're going to decrease the efficacy of our treatments. But you certainly could use the Synercool afterwards, after we're done. The basic protocol is you use the anesthetic. You remove it with water and water-soluble cleanser. If there's any oily residue, remove with alcohol. We did actually use alcohol. That was part of our protocol on everybody's patients. You pick your program, A, B, or C. You complete 1 pass on the entire face, which will probably need 2 tips. And you can cool immediately post-treatment if necessary. We had not found it necessary for any of our patients. And then you can protect the skin with a high-level sunblock and use whatever post-skin care you desire. Typically, we would recommend that they use maybe 2 to 3 days of something relatively occlusive like Aquaphor and sunscreen in the morning. So also you can pick your laser by emulation. If you want low downtime for some superficial texture and scarring, you would use Program A, Program B, more medium downtime for pigmented lesions, and Program C will be more high downtime to get more deeper wrinkling and scarring. And this is the quick reference guide for the protocols. Basically, if you're going to be in Program A, you either get a 5 or 10% coverage, and you can go from 2 to 10 joules. From B, you can go from 6 to 16 joules, and in C, you can go from 10 to 20 joules. You want to have the applicator tip clean and dry. You open the tip. It's really very easy. It snaps right on. Hair is a problem because it will singe, and sometimes it will then create some char. So usually we want the area to be well shaved or clipped smoothly, clean and completely dry the skin, and you do not use any gel, lotion, or coupling medium. So it's on dry skin. You set the treatment parameters, and you might want to use a test spot tip to confirm the patient's applicability for treatment and establish and confirm treatment parameters, and then proceed. It usually does take about 20 minutes, 10 to 20 minutes to actually see the tissue response. The treatment consists of a single pass over the entire area, and the applicator tip should be positioned in the target zone. You hold the applicator tip perpendicular to the skin and in full contact with the skin surface, but it's very, very easy to do. You trigger the pulse with the trigger, and then you lift the applicator and move it on to the adjacent spot of the skin, and then you attempt to do this without untreated gaps between the positioning of the handpiece. And you don't really want to overlap the treated zone either. And this so far has not been cleared for treatment on the eyelids or the lips. So, and the number of treatment sessions depends on the individual patient. In our study, we did 3 sessions. And in terms of touching up, that's anybody's guess in terms of maintenance. Post-treatment, use an emollient cream. If you have some discomfort, you can use a Cinerocool or cold packs. Treat any blistered or ulcerated skin with antibiotic ointment or burn treatment cream. It is normal to see tiny little scabs of less than 1 millimeter in diameter at 24 to 72 hours post-treatment, and these remain for a few days, so we have to instruct our patients not to touch or scratch them, and they should be allowed to shed off naturally. Fortunately, they're really not that noticeable, and most of our patients, the female patients, were able to go about their business immediately afterwards with makeup on. During the first 2 days following treatment, care should be taken to prevent trauma to the treated site and avoiding mechanical or thermal damage. In addition, since many of you may be Syneron users, I really can't tell you that I would recommend that you do, for instance, a Trinity and then immediately following do the Matrix, because I don't think we've really established that that would be safe to do. That may be a little bit too much heating for the skin. The moisturizer may be applied several hours a day, and makeup may be applied after 24 hours. Generally, 24 hours after the treatment, the patient may resume regular soaps but not use exfoliants, and obviously tanning is not to be allowed. And this is just to show you before treatment 1, immediately after treatment 1, you get kind of this redness, which really goes away after about 2 to 3 hours. And then 1 day after 1 treatment, you can see these little dots here. 2 days after 1 treatment, they're starting to come off, and it just gets better and better. So I'm sure you want to see a few before and after pictures. Here's one of Dr. Haruz's patients who had 3 treatments, I believe, 4 weeks follow-up, and this was the energy. She was treated in the periorbital and perioral area, and I think you can see some pretty nice results here, not only with reduction in wrinkles around the eyes, but also quite a bit of tightening here. He did not treat this area. We just said don't treat the eyelid, but he did treat all the way around here, so there's certainly a good bit of tightening there. And you can also see the tightening in this area where there's been a diminution in the depth of the nasolabial fold, an improvement in the upper lip ridid here, and an overall just smoother tone of skin. A lot of patients comment on how bright their skin looks. Again, same patient on the other side. You can see still some tightening here. This is much better than it is over here. And the overall smoothening of the skin, which is very rough, and now is much smoother and more bright. There's another patient of Dr. Haruza, again, with perioral riddids that did quite well, a little bit less hooding here, and a reduction in the depth of the nasolabial fold. There's also a good reduction in these kind of cheek wrinkles that are more passive. Very nice clearing of that area. This is one of my patients, again, to show you that this is the kind of thing that's really quite difficult to treat. I find even Botox may help this patient, but not that much. And here we've really been able to clean her up and get rid of her periorbital wrinkles. Similarly, even deeper wrinkles do quite well. And she did quite well. And if you look again at this hooding that is now missing here, again, we did not treat in here, but we treated this whole area. This patient actually got full face treatment. Most of my patients got full face. Again, very, very fine lines, very difficult to get rid of, but she did extremely well. This patient has some tightening in this area and a very deep nasolabial fold here, which is less reduplicated, and the skin is much clearer and finer. This is a pretty old patient, which, it's not that she looks a whole lot younger, but she's got marked decrease in these folds, and also a marked decrease in the redundancy. She had a lot of tightening. She's very, very happy. And patients like this aren't really going to be willing to undergo a huge amount of downtime. And she was very happy with. All our patients were actually quite happy with the results. Again, fine lines around the eyes. This is a full face patient. One of the things I really like about this treatment is I'm sure you all have a certain number of patients that no matter what you tell them are like adamantly against Botox or fillers or both. And I think that this is a treatment we could offer them now where you can see that she's had quite a bit of reduction here in these deep folds and in her forehead lines, and you can see that she's had some brow lifting here. And also, again, nasolabial folds, and you can see also that she's had quite a bit of tightening in her cheek. She has much less redundancy now in this marionette line and nasolabial fold. And here's a side view of that same patient, again, showing you that kind of brightness to their skin where it was dull before. She had a lot bigger pores and all these wrinkles, and now she's smoothed out and she pulled back a little bit. Another close-up of the eye. I think some of these are, I'm sorry, for some reason I got too many of the same pictures. Here's another patient who doesn't necessarily have like lines that you can point to that are better, but she has a much brighter look, and she just looks younger. Now, I can't really put my finger on it. It looks like maybe she got some cheek tightening and a little bit less redundancy here. She was extremely happy with her results. This is another patient who really had a lot of, she's relatively young, in her late 30s, a lot of aging and a lot of laxity. And this, I think, really pulled up her cheek. It took down her nasolabial fold, made this less, and actually made her overall lip ridged, I thought, less. So Dr. Russo was really impressed with the periorbital wrinkle improvement, and his patients had a very nice improvement in a range of non-ablative original Fraxel Restore. And actually that really, considering that that was the program kind of that we were using, similar to Program A, that would be expected. And a few patients had some nice cheek improvement. He thought it had more efficacy than a photofacial and much more textural improvement. And he thought that the MatrixRF was going to be seen as a great add-on to Trinity and for ridges around the eyes. I liked the treatment a lot in terms of it was extremely easy to perform. And I was actually surprised by the results and the downtime because patients really liked the procedure. You know how sometimes you have to show before and afters to patients? They didn't even care about their pictures. They were happy. People had commented to them. Their skin looked better. They found it very easy to tolerate. There was virtually no pain, at least with the settings that we used. And they had no problems covering it with makeup and going back about their work. And so, although I can't say that the results, because I haven't had as much experience with the fractional CO2 settings, quote unquote, and I don't have that much experience anyway with fractional CO2, but from what I've seen in terms of before and after pictures, they're pretty striking. And so I think that this might be a way to compete that doesn't have as much downtime, because I find in my practice that the number one thing people don't want is downtime, and the number two thing they don't want is pain. So I am excited about the possibility of being able to treat wrinkles and tightening at the same time, which I don't think, with the same technology, which I don't think is something that we've had prior to this time. So if you look at resurfacing for wrinkles, we talked about CO2 being the gold standard, multiple complications, long downtime. Arbor resurfacing was a response to that, less complications, less downtime, but less improvement. And I think now maybe we have this a tunable radio frequency device, which is really a first, and we can actually change the settings on it to kind of mimic three different kinds of ablation: the immediate, the delayed, and the subcoagulative, and the various kind of combinations, so that we may be able to get the best of both worlds just by dialing in what we want. And then finally, I think that the biggest the biggest plus, as I said, was combining wrinkle reduction with tightening. I also have a video that I would like to show you, and hopefully I will be able to get it up. So if you just give me a moment.
Hi, I'm Taub. I'm an advanced dermatology in San Fran, Lincolnshire, Illinois. We're going to show you a little bit about this new technology called the MatrixRF, which is fractional radio frequency.
Talking about the applicator. Unfortunately, you can't hear the sound.
It fits.
I'm just explaining it, showing the
module, and it's very light.
Showing the screen, showing how to put on the tip, as you can see, although it's not quite in there. Just snapped it right in, and it's on pretty well.
Now we're going to perform the treatment.
And this patient wanted eye shields. So, in case you're wondering, this is radio frequency. So the nice thing is you do not have to cover people's eyes, but she wanted to have the eye shields on. She's had other laser treatments in the past, and she just didn't want to, she felt like it was going to distract her. And we do have an evacuator there because you do get a plume of smoke, so you do need that. Basically, it's just as simple as,
how is the pain sensation?
Obviously, this was edited, so we're not showing you the entire treatment.
If she has had
But
topical
skip around
anesthetic,
a little bit. At one point, I think it's coming up, I say to her, how are you doing? She said, fine. I can kind of feel a little bit of heat or warmth.
you can see after a few minutes
After a while, about half an hour, you get
some
kind of like a red, little bit welty
We're
appearance.
going to start on the second half of her face now. She told me just now that she only has a little bit of tingling on the right side. No,
I think I'm asking her now about the pain. She's saying,
and
no,
you can see this also just to show you
not a
how
big deal.
light the
Feels a
scan
little
piece
warm.
is.
Now I'm saying, look at how easy it is to hold this.
Very, very light.
Really about as heavy as my cell
One of the
phone.
unique things about this
I
technology,
do have a heavy cell
which
phone.
is something that everybody's wanted for a long time, is that not
Dr.
only
Taub?
you get wrinkle reduction, but you also get smoothing, you get pore reduction,
And I'm going
you get a
slow.
much brighter look
I mean,
to the skin,
there's really,
but you also
in
get
terms of, I mean, usually we call it hurts, but actually this thing will really pulse as fast as you want it to. So I'm going pretty slow, mainly because I'm making the movie, and also because, I don't know, I was just demonstrating. But if you're a quick person, you could probably get this full face done.
Scale of 0 to 4, how would you rate that?
A little over a 0, between a 0 and a 1, I would say. Again, just a slight awareness of this.
Having a little bit of heat.
And with the last two treatments,
She's also, at one point I asked her, how was this? Because this was like her third treatment. Did you have any problems? After the treatment, did you have any downtime? Were you able to go about your business? And she said, yes, I had no problems at all.
felt that you were able to cover it.
And we did 20 patients. We did not have any patients. We had no complications, 0. And everybody was pleased. We got no phone calls. So that's it.
Dr. Taub,
Yes.
we have a few questions for
Sure.
you. Let's see. Does the procedure have to be done by physician, or can laser technicians under medical guidance do the procedure?
Well, I think that varies by your state and also by your comfort level. So yes, I personally would have other people do the procedure once I train them on how to do it.
Okay. Next question is, what about pigment changes with just perioral or periorbital treatment?
It's a good question. We did not see any demarcation lines with the patients that we did. And so I have to say that we also didn't, we had them dialed more for the program A, I believe, which is more focused on texture and wrinkles. And we didn't have people with a lot of photo damage in terms of like brown patches. We did see some improvement in a couple of people that had that, but for the most part, the people, for some reason, that we selected didn't have a lot of brown spots, and I think you would probably use more program A. So I think that just like any ablative treatment, if somebody has a lot of photo damage, like, for instance, over their whole face, and you're going to ablate only the area around their mouth, then you may see a line of demarcation. And I think with most of these but if somebody doesn't have that, then you won't. Like, I don't think it actually causes hyperpigmentation or hypopigmentation, but it could cause what we call relative hypopigmentation. So, like, let's say your whole face is covered with freckles and you only treat the periorbital area. If you remove the freckles from the periorbital area, you're going to have a line of demarcation if there's freckles all over the face. But that said, with most people who don't have really pronounced photo damage that is more pigmentary, I don't know that it would be an issue.
Very good. One last question.
Mm-hmm.
How would you incorporate this treatment with the Trinity?
Okay. I think how I would do it would be to possibly, instead of doing, we were talking about this in our office, how we were going to do it. We were thinking like kind of making it shorter. So in other words, they would come in every 2 weeks. They would have the Trinity on day 1. They would have a MatrixRF on day 14, a Trinity on day 28, MatrixRF 2 weeks later, a Trinity 2 weeks later, and a MatrixRF 2 weeks later. So it would be 6 treatments, 3 Trinities, and 3 MatrixRFs, and a follow-up at 1 month. And so the question is whether or not that would be enough, or if you would want to, do all 5 treatments. I think that's just, we'll have to see. We got a lot of results out of 3 treatments. The other possibility is that you could just say you're going to do the Matrix with the first 3 treatments and continue the Trinity on for 5 treatments. I think I would be a little nervous about doing all 3 aspects of the Trinity and the Matrix on the same day. The reason I would be nervous is that, you usually do the Refirm. First you do the Elos IPL RF, then you would do the Refirm, and then you use the Matrix IR focally. But don't forget, with Matrix IR and with Refirm, you're kind of radiating heat for a goodly bit of time, like an hour. So if you come back then and do Matrix RF over that, the heat which is radiating up from deeper areas could be heating like mid-dermis and upper dermis. I think that could cause you to have a much more significant wounding from the Matrix than you were intending on having. So I think at this point, until we know more, it could be a little dangerous. If you were doing just the IPL component, like let's say you wanted to do a photofacial, but you wanted to have a super photofacial where you also got textural improvement, then I think you could do the photofacial first and do the Matrix second on the same day. But when you add in the Refirm and the Matrix IR, which are deep heating and radiant heat for like an hour afterwards, I think you have to separate it. Now, you could do it the next day. You'll probably even do it like later that afternoon. But I was just thinking from the point of view of the patient, maybe you would think, they come in every 2 weeks for 3 months, and that's kind of like the package deal. That's the way we were gonna approach it.
Great. Thank you very much, Dr. Taub, and thank you everybody for joining the conference today. And we appreciate your time.
Thank you.
Thank you. Goodbye.
Bye-bye.
Thank you. Please note that you may view the recorded webinar at www.cineron.com.